You're back on another edition of the Kentucky Hospital Association podcast. This is Trey Watson, joined as always by KHA Communications Director Ginger Dreyer. Ginger, how you doing?
I'm doing great, Terry. How are you doing today?
Oh, wonderful. I'm waiting. I think we were in uh false end of summer we kind of get
Yes.
cold for a couple of days and then got hot again.
Yeah, we're warm again. So it was definitely false fall.
Yes. All right. We've got Jim Musser back in the podcast today. Jim is the Vice President of Government Policy for KHA. And Jim, I know there's a bunch going on. Obviously, Washington, D.C.'s plowing through trying to get a budget and a presidential election. But as always, policy continues to march on here in Kentucky that we have to pay attention to for KHA members and the Commonwealth as a whole. So I know we want to talk a little bit today about the 340B program. Let's start off with, we always talk about kind of the two buckets of listeners to the podcast, the people who are just interested in healthcare that may not be in it, and the hospital centric people. So for the non-hospital centric people, why don't you start with the elevator speech definition of what the 340B program is?
I can do that, Trey. Thanks for having me on. It's great to be with you and Ginger. Before I get to that elevator speech, though, the thing that makes the elevator speech possible is the fact that this is the 17th of September, and in 1787, we were given a constitution, and that formed our current government. And we're also fortunate to have that kind of document. After more than 230 years, we have the longest known constitutional republic in the world. And we're also very fortunate to live in a country that has our liberties guaranteed in writing. Our mother country, Britain, talks about having a constitution, but it's not a written constitution. It's a theoretical constitution. We have the real thing. And so much of what we are today is because of the work of those founders back in the 1700s. So salute to them and salute to us for being able to keep that constitutional republic for well over 200 years, and may it have at least another 200. So
it's the perfect time to celebrate.
Absolutely. And shifting to what you actually asked me, Trey, the 340B program arises out of the Public Health Service Act, and it is a really interesting kind of program because, unlike most government programs, it's not paid for by the government. It's paid for directly through savings generated by the sales of prescription drugs at a discount to our hospitals. And that's really important because, as you might imagine, the hospital's biggest expense is in the salary for all of those well-trained people that are there serving the patients. The second largest expense is prescription drugs for those patients. And so the 340B program allows the hospitals to generate a whole lot of savings. We don't get the drugs for free. The pharmaceutical companies aren't giving them away. We purchase them, but we purchase them at their best price. And that means we're buying those drugs at the same price that they'd be selling to the federal government or the government of Canada, somebody that's kind of buying them in bulk. And so we generate a lot of savings. And that savings then goes into serving people who can't afford drugs, or maybe need oncology services or behavioral health services, or any number of things, up to and including simply helping the hospital to keep the lights on and the doors open in some of our small rural hospitals that are very financially pressed. This is the program that makes a difference for them between being able to serve patients and not serve patients. So it's a tremendous program.
Yeah, I'll preface it by saying this. And you and I have talked about this, I think, on previous podcasts, and we talked about it offline a bunch. I know that there's a lot of people out there, you and I among them, who are small government fiscal conservatives, strong believers in capitalism, and a lot of people that share our beliefs sometimes object to programs like this, but I think it's important to remind people that we as a society have decided that there is larger social benefit to healthcare, and that we do not in fact have a capitalist healthcare system. And so because of that, occasionally programs like this are necessary to make sure that we can continue to provide the standard of care that, again, we as a society have freely among ourselves deemed to be of benefit to the country writ large.
I think that's exactly right. And I would add to it, this isn't using taxpayer dollars. The only taxpayer dollars involved are whatever dollars the Health Services and or Health Resources and Services Administration, HRSA, which has oversight of the program. It's part of the Department of Health and Human Services. So the only federal dollars involved in this program are what are used for oversight, to conduct audits, to make sure that the hospitals are being good stewards of the program. And the great news is, here in Kentucky, our hospitals have been great stewards of the resources. The whole program was put into place back in the 1990s. The program is old, and it has grown over time and grown with the express consent of the pharmaceutical companies. It hasn't been imposed upon them. And some people say, oh, it's price setting. Well, the only ones setting the price are the pharmaceutical companies. So the program really isn't some kind of anti-capitalist scheme. It was really kind of the price the pharmaceutical companies agreed to pay to be at the table to negotiate other things that were of interest to them, like Obamacare. The latest expansion of it came as a part of the ACA. And of course, there's been a growth in spending because the program's really tied to outpatient medication. And with the growth of outpatient treatment, there's been significant growth in that. And as part of the deal with Obamacare, they agreed to the greater use of, they being the pharmaceutical companies, agreed to the greater use of contract pharmacies. And that's particularly important because a lot of hospitals, particularly small rural hospitals, don't have an in-house pharmacy of their own. And so they rely on a contract, excuse me, they rely on a contract with the CVS or Walgreens or Walmart or the Rexall that's owned by the Smith family down the street. And so in objecting to the growth of this program, in trying to undermine it, the drug companies really are forcing our legislators to make a choice. Are they going to stand with their local hospital? Are they going to stand with their local pharmacist? Or are they going to stand with multinational drug companies that are, quite frankly, raking in billions in profits? You know, those who had objections to government imposing a vaccine on everyone ought to be very much in favor of this program, because these are the same companies that were reaping the billions in benefits from that government imposition. So, you know, stand with your local people. You know, I don't think Novo Nordisk or Pfizer is going to have any financial difficulty because of this program. J&J is one of the largest. Johnson & Johnson is one of the largest pharmaceutical companies in the world. And look, I'm capitalist through and through. I want all of them to be successful and make money, and they do. And this program isn't sending them into bankruptcy, but taking the program away will absolutely cause some of our hospitals to close their doors. It will cause others to stop being able to provide oncology services in the local community, and patients will then have to drive an hour, 2 hours. We'll have to spend money out of pocket for a place to stay and for meals away from home. And when you don't feel well in the first place, the last thing you want to be is in some strange place trying to get meals from some strange place. It's the program works, it's highly effective. And for those who complain of transparency, the pharmaceutical companies and HRSA can audit anytime, and we are subject to annual recertification, and there are ongoing audits of the program, and we can show exactly what we're doing with the money that we save. Study by HRSA shows that nationally 80% of the savings go into oncology programs so that people in rural areas can get cancer treatment close to home. And that's very similar here in Kentucky. We also are seeing our hospitals use the savings for crucial things. Excuse me. It's allergy season, and I'm feeling the effects of the ragweed today. But we see the effect of the program on people who can't afford their prescription medication. For instance, the University of Kentucky has a program that if you are prescribed Stelara, they will ask you, can you afford a $40,000 a month copay for this out of your personal pocket? And when you say, no, I cannot, my name is not John D. Rockefeller, they will say, okay, we will use our 340B savings and we will pay down the cost so that your out of pocket is $50 a month, not $40,000 a month. And that's huge because, again, prescription drugs are very expensive. The specialty compounds that go into treating cancer patients range from $60,000 to $100,000 per infusion. And very few of us could afford to pay what we would have to pay out of pocket. And this program really goes a long way toward making it possible to treat those patients. The savings are also used for things like.
And I should say, on that point, the healthcare worker important in my life sees a tremendous amount of patients readmitted to hospitals because they said, well, I couldn't afford to continue taking my medicine. Well, when the doctors have identified a problem, prescribe you medication that will keep that problem under control, and then you don't take it, the chance of you being readmitted are high. The chance of you being readmitted with a more severe issue than the previous admittance is higher, which means it's worse for you as far as a health outcome. And again, it puts more burden on the states, Medicaid, Medicare dollars at the hospitals themselves, the insurers. It just costs more for everybody. When if we just take a little bit of money and made sure they could afford the prescription, the chances of a better outcome and cost savings for the general public are much higher.
Trey, you have hit on one of the keys for healthcare more generally. We never ask the question, how much will it cost if we do nothing now? Because quite frequently, the upfront cost is going to be a lot cheaper than it is if we're waiting until the person is much sicker. If the acuteness of the illness is greater, the cost of treating it is going to be greater. And all of us in society are going to bear that cost because, as you quite correctly pointed out early on, we've made a decision that healthcare really isn't part of the free market. There are social benefits beyond what the free market might recognize, and we've made a commitment as a society. And quite frankly, we don't always make that commitment in the smartest way that we could. And a lot of times asking what would be the cost of doing nothing should be the first question that we ask, not finding out after the fact that doing nothing really drove up the cost. And we see this quite frequently with patients who can't afford their insulin. And I think it's kind of funny, those who have complained about price setting have engaged in some price setting of their own when it comes to talking about insulin costs and putting some caps on that. And I'm certainly not saying that it shouldn't have been done. Just as an aside, the scientist who figured out how to develop insulin for use in human beings patented it and sold the patent for the grand total of $1 to the University of Toronto, because his desire was for anyone who had diabetes to have ready access to insulin. And what we have seen is pharmaceutical companies have made good changes to it. It's not the same as the old raw insulin, but they frequently have raised the prices dramatically, looking at not the patient's health, but at the health of their bottom line. Understand, they are free market companies, but when you take an EpiPen that was $80 and suddenly raise it to $300, or you have $1,000 a month for your Wegovy and it costs $5 to make the drug, there's got to be some recognition that there's an imbalance in the market and something needs to be done to protect the patient.
And look, especially when the government is on the hook for in the Commonwealth of Kentucky, we're still around 60% of all patients sitting in a hospital are on Medicare or Medicaid.
It's actually more than that. It's between 70 and 80%
Yeah.
of our patients are on government pay.
So the government has an interest in saying, okay, we're footing the bill for this anyways. If you've been diagnosed with this issue where if you take this pill once a day, you won't have a stroke, and the cost on the back end of treating a severe stroke is going to be long term, because it's you could be talking anywhere from some sort of long term inpatient care to home nurses to you don't even know what the cost could end up being long term, or you can just take this pill once a day.
Like that's going to be tens of thousands of dollars on the back end.
Yeah. So the government has an interest in finding a way, whether it's inserting themselves or like they've done with 340B, negotiating between the different players, finding a way to ensure that the patients who are under the government's care basically can afford to take that one pill a day to prevent a greater taxpayer cost on the back end.
Now, are all the hospitals in Kentucky, are they all participating in 340B, or is it only some hospitals that can do that?
That is a great question, Ginger. And the answer is the hospital has to be a nonprofit, community hospital, sole community hospital, that is, critical access hospital. Our tax-paying hospitals, we have both in the state. The vast majority of our hospitals are not-for-profits, and probably 75% of our hospitals are able to participate in the 340B program. But the tax-paying hospitals, because they are tax-paying hospitals, aren't able to participate. And it's really unfortunate because they're treating the same kinds of patients that the nonprofits are. They're treating indigent patients. They're treating patients who are being paid for primarily by the government. And they really ought to be able to participate too, because ultimately all of this comes down to serving our patients. That is always, every day, our touchstone, making sure that the things that our hospitals are doing are in service to the patient. And this program is critical to that. And I can't imagine anyone with a financial hard head or a generous heart would look at this program and say, oh, it needs to go away. I think there's a lot of confusion about the program. It's a federal program. It has a state component, and that always makes it very complicated. Right. And so I think a lot of the folks who look at it and have been convinced that there's some problem have really been kind of misinformed. And we are happy to be an honest broker. Happy for them to fact check me. Not a problem at all for them to fact check, because I can show you what our hospitals are doing with the savings, and it's exactly in line with what the law says we should be doing.
Right. And a lot of people are thinking that they're giving the drugs to the hospitals for free. And I think that's a big misconception. And you spoke about that, about how it's just giving them a fair price that other big buyers are going to be receiving from the pharmaceutical companies.
That's right. They're still making a profit. They just like to make more profit. And I understand. I'm an investor. I invest in drug companies. I want them to be successful, but I don't want them to be successful at the cost of our patients' health.
Right.
I'll also say, you talked about supporting your local interests. Jim. It could be a different. If we were in Indiana, for example, you might it might at least give you pause because you have Eli Lilly, Ohio's got Johnson Johnson. There's pharmaceutical companies have large footprints across the country, and in most states, Kentucky is one of the few that we have very little pharmaceutical industry footprint in Kentucky. So, even if you want to think just more kind of selfishly, if you're a member of the General Assembly trying to weigh interests of industry in your area versus the pharmacies versus patients versus hospitals, there's very little pharmaceutical industry presence in Kentucky to kind of or even to make you look that direction.
That's exactly right, Trey. You have hit a key point. Our hospitals are employing over 84,000 Kentuckians. We add over $14 billion to the state's economy. And to my knowledge, there's not a single prescription drug manufacturer
There's not
headquartered in Kentucky. We're not manufacturing any drugs. We don't have a headquarters here. So if this money is savings, and the way the pharmaceutical companies have been doing things recently, they've been refusing to deliver drugs at the agreed upon federally determined price in Kentucky. But other states, Arkansas, Louisiana, Mississippi, Missouri, Maryland, West Virginia, Michigan, have already passed laws that require them to deliver the drugs at the agreed upon federal price. We are seeking legislation to say, if you're doing this in other states, you must also give us the same benefit here in Kentucky, because we know how it operates. If they're selling them at a lower price in all those other states, the price is higher here in Kentucky. And we don't think that's right, not for our hospitals and not for our patients. It's a matter of, if it's right for everybody else to receive this benefit, it should be right for Kentucky too. I can't imagine any member of the General Assembly saying, oh yeah, give that benefit in West Virginia and Missouri, but screw our people here in Kentucky.
Yeah. It's basically saying send that money to Indiana.
That's right.
Especially since it's
not to pick on Lily, they're just close.
Well, it's always good to pick on our neighbor Indiana.
That's exactly right. And look, these are great American companies, most of them. There are a few like Novo Nordisk that are based in Switzerland. I would much rather see resources spent here in Kentucky than going off to Zurich. But that's the choice that ultimately they're going to make. Are they going to stand by? And here's the other part, Trey. Our hospitals are the largest, or in the top 3 largest employers in every county. Even in our large urban counties, Jefferson and Fayette, still huge employers. So, let's look after our own employers. Let's look after our own people and their health. And I guarantee Johnson & Johnson and Pfizer and Eli Lilly are all going to be just fine.
Especially since this is a price that they have set, that they agreed on. It's in law. If they hadn't already agreed to it, you might understand a little bit more, but this is something that they have set themselves. So it's really not fair to Kentucky if other states are getting what the pharmaceutical companies have already agreed upon, just because we don't have a separate law forcing them to do what they've already said they would do.
Yes, the problem at the federal level all along has been that HRSA was given oversight, but really not given much enforcement power. HRSA has, by and large, agreed with the hospitals, but the pharmaceutical companies have said, what are you going to do about it? And so there have been a number of lawsuits, and the pharmaceutical companies had sued in Arkansas and other places where these laws have been put in place. And as of today, as of September 17th, 2024, they've consistently lost, including in the 8th Circuit Court of Appeals, which covers Arkansas and several other states. So I think probably their strategy is, let's find a circuit that will agree with us so that maybe we can get to the Supreme Court and maybe we can get rid of the program entirely, or have some leverage to make some changes to it. But until the program is changed at the federal level, this is what the law requires, and we just want them to comply.
I think that's completely fair.
Yeah. Well, Jim Musser, thank you for a discussion on 340B, and hopefully we can look towards maybe some legislation once we get into the General Assembly for the year 2025, which I cannot believe is almost here.
Coming quickly. Thanks again for having me on today, and hope you and everyone within the sound of my voice has just a wonderful Constitution Day.
Ginger, do we have any member updates or association updates to share?
Just want to remind everyone that the Health Policy Conference is coming up in October. It's quickly upon us. How it's already October almost, I don't know. But we want to make sure that everyone comes out for that, all our members, to be a part of the conversation with the policymakers, both from Washington and Frankfurt. We're going to have some great guests with us in October. So check us out on KHA.com. The event calendar will have all the information and all the latest on all the speakers that are going to be there. It's going to be a really exciting event this year, and I hope all our members can join us.
We hope that we will see you there, and we hope that you will follow the podcast. Give us a like and a follow wherever you stream your podcasts, and we'll be back next time on another Kentucky Hospital Association podcast.